morning, everybody. This is Katie Myatt with the Kentucky Department for Public Health. We can go ahead and get started. I think we have just about everybody that was going to log in today. This is being recorded and will be posted on Train for any other staff that will need NEDSS training and disease investigation training. We do have a mixed group here today. So as far as the regional coordinators, we also have some KDPH staff. So I'm going to do my best to mix everything that everybody needs to know. But be sure to ask questions if I'm not clear. I've tried to clearly notate what is important for KDPH staff entering cases and what is important for local health departments. But I could have certainly missed something, so definitely ask questions. I don't believe everyone is muted, so you should be able to just pop in and ask a question. Alternatively, there is a questions box, so you can throw some questions in that box as well, and we can try to go through the training and clarify any details that need to be clarified throughout the training. So just today, I want everyone to be comfortable. I want this to be as clear for staff as possible. So make sure that you're asking questions. I don't mind to get interrupted. I can get going pretty quickly through this content. So make sure you interrupt me. I don't mind, and I want everybody to really understand what's going on. So for regional coordinators that are going to be doing contact tracing and tracking, you have several other trainings that you're going to complete for us on Train, and you'll probably hear some of the disease investigation details in those trainings as well. I'm going to try to hit on the Kentucky specific details, and especially as it pertains to NEDSS, and try to show the flow from NEDSS into our Deloitte contact tracing and tracking system, which is where you're going to be doing most of your interviews and data entry. But you'll still get some of the principles in those other trainings as well. So this is really jurisdiction specific. It is what we tell people here at KDPH. So you'll still need to get in touch with the regional EPI or your contact at the local health department to make sure that you're doing what they need you to do as far as data entry goes and where physical documents are and stuff like that. So that long-winded intro is over, and we can go ahead and get started. I want to start out for at least the regional coordinators an overview of reportable disease surveillance in Kentucky and kind of what sets up how local and state public health can identify cases and mitigate the spread of disease. And in order for us to mitigate the spread, we have to know what diseases are being diagnosed out there. So in Kentucky, we have an administrative regulation. It's 902 KAR 2:020, and that's our reportable disease surveillance regulation. And that tells us from healthcare providers what is being diagnosed. So there are two parts. There's a laboratory requirement and a healthcare provider requirement, and each one of those are given a specific set of data that they have to report to local public health. We are a decentralized or home rule state, so that means that investigations are conducted on the local level. And so we want healthcare providers to really notify local public health of any diseases and conditions that they're identifying. Laboratories that have to report to us, it's pretty limited. They have to report patient demographics and lab test results, basically what they would have on any reportable condition. Healthcare providers, we want a little bit more detail, and it's mostly case information. So we want patient demographics, clinical data, so signs and symptoms, epidemiological data, so are they a healthcare worker? Are they a food service worker? Is everyone in their household sick? Did they attend a social gathering where we have lots of people that have presented to the emergency room? And then we also want our healthcare providers to report to us laboratory data that they have as well. So ideally, and this is ideal, you would get on every patient a lab test result from the lab who performed the the testing, and then you would get a case report from the healthcare provider to local public health. The public health department matches those reports up, and then they have sufficient information, hopefully to meet case definition if everything's there. If not, they have enough information to look for more, either from the ordering provider or to contact the patient and conduct their public health interview. Within this regulation, we have a list of routine reportable conditions. Kentucky follows the nationally notifiable disease surveillance system and the list of diseases that CDC and the Council for State and Territorial Epidemiologists set as being nationally notifiable. In addition to that, we have a couple that are just reportable here in Kentucky, and the two that I can think of are histoplasmosis and toxoplasmosis. And so we can add additional conditions to that list based on what we see here in Kentucky. Because this is a state law and it requires comment and approval by our legislature, and that takes time. We also have language in there about outbreaks and unusual occurrences. So we have this list of discrete conditions that are reportable: salmonella, E. coli, TB, STIs, and stuff like that. But we can't foresee every disease that may come about or every outbreak that may come about. So this language is really, if a healthcare provider or a lab sees an unusually large number of either routine reportable conditions or novel conditions, then we would want them to report that to us. Outbreaks here in Kentucky are defined as 2 or more cases that are linked by a common setting or anything that's kind of unusual for the state. So 1 case of measles here would actually be an outbreak. And then this is really where COVID sits. So coronavirus 2019 is a nationally notifiable disease as of a couple of weeks ago, but we haven't modified our regulation to include that on one of our lists. However, it is reportable under this language of outbreaks and unusual occurrences. It's a novel pathogen, and therefore a new disease, so we want to make sure that we have reports from all healthcare providers and laboratories. In addition to the list of reportable conditions, we also tell healthcare providers and laboratories how and when they have to report. So every disease is given a timeline. It's either you have to report it immediately, within 24 hours, 1 business day, or 5 business days. So things that spread really quickly or have great outbreak potential, we want to know about that sooner than something that like hepatitis C, for example, that we have a little bit more time to investigate. So that would be a 5 business day rather than an immediate. For laboratories, we like for them to report electronically. We modified our reg in 2015 to ask that all Kentucky laboratories report their test results electronically through our Kentucky Health Information Exchange. That's easier said than done, and I think every lab is working on that, but we do get a number of labs that come in directly to our surveillance system, but we also get a number of labs that report to us via paper simply because they haven't connected to the Health Information Exchange yet. Healthcare providers are kind of given a little bit more leeway. They don't have to report to us electronically via the surveillance system, and they can really do phone, fax, secure email, however they can get that report into us. For the most part, those are going to be faxed case reports. So before I move on, does anybody have any questions about the reg?
Yes, Katie, there is one question.
Data flow in a routine, I call it routine, it's not really routine, but an outbreak case investigation really, again, starts with the local health department and moves up through KDPH. So we're bringing in those reports from healthcare providers and laboratories, and they go to the local health department. The local health department enters those cases into NEDSS, which is if I didn't say it already, the National Electronic Disease Surveillance System, or Kentucky's surveillance system, and that includes demographics, morbidity, mortality, exposure data, treatment data, and contacts, as well as lab data. Once the local health department has entered sufficient information to meet case definition, then they can send a notification to staff at KDPH, which is basically a subject matter expert that will review everything that they've entered into NEDSS, make sure we meet case definition, and then approve that notification so that we can transmit data to the CDC. So not only do the local health departments need to report to KDPH, but KDPH needs to report to the CDC. So that notification is just a way of moving the data from each level to the next level, and ensuring that we have some checks in there that make sure by the time it gets to CDC, we have good, clear cases that won't have to be cleaned up too much when it gets there. Once we approve cases, that's when we here at KDPH extract the data and then analyze. For the most part, during an outbreak investigation, we pull our cases from where that teal arrow is, and those are approved notifications. So at least the subject matter expert here at KDPH has reviewed to make sure that we have sufficient info to meet case definition. During the time of this pandemic, in an effort to be very transparent with the public and to identify and investigate cases very quickly, as soon as we get a healthcare provider report, mostly the lab test result, we're going to investigate that case and put some public health action in there to reduce the spread, so isolating cases if they need to be isolated, quarantining contacts if they need to be quarantined, and then we're providing a daily count to the public so that they can see the spread of disease. And so that's what that red arrow is. We're counting cases a little bit sooner than we usually do, which means that for regional coordinators, there's the opportunity for duplicates and for counting of cases that might have to be pulled back later, especially because some of the info that you get on patient demographics can be fairly limited. Our population is very mobile. We move around, we seek services outside of our county of residence, and therefore if we don't have sufficient patient demographics, it's possible that we're counting cases either that don't live in our state or that we count them in Shelby County, but they actually live in Jefferson County. So a little bit more data quality work has to be done because we're counting cases a little bit quicker than we normally do, but we will go through some ways that we can address that, and then I'm sure your local health department staff will have some workarounds for those as well. For data streams here at KDPH and at local health departments, they're basically the same. We have a paper stream, if you will, which is method 1, and an electronic stream, which is method 2. So we are receiving paper from healthcare providers here at KDPH that local health departments are not receiving. So those are faxed, phoned, emailed reports that are coming directly to us. We are monitoring those faxes and those reports, entering them into NEDSS, starting with the lab, opening investigations for local health departments, and that allows the local health department to process that report, make sure it meets case definition, and to perform their contact investigation. The second method is the electronic method, mostly for lab reports. So typically, electronic lab reports that come into NEDSS are monitored by the jurisdiction where the individual lives in an effort to keep our system functioning. Because we have so many labs coming in, KDPH staff are monitoring those electronic lab reports and opening investigations for local health departments, and then the local health department can process. You'll see this when we get closer to the NEDSS work. there are several queues, and the local health departments really function out of those queues so that they know what's new and what they've already done. And so this is a little bit different. This is taking them out of a queue that they typically work through and having them only work in the open investigation queue. And really for KDPH, we don't typically work through the documents requiring review queue. We let the local health departments do that. But again, to keep the system functioning, we need to kind of centralize that effort and open investigations for local health departments. The same way that we have paper reports coming into KDPH, the local health departments have paper reports coming into them, but that we don't have here at KDPH. So they get fax, phone, secure email, any kind of paper-based report from healthcare providers and labs. They enter those into NEDSS, make sure everything meets definition and send us a notification when it's met. They can update those investigations as necessary and then close out their investigation when everything's complete. And then method 2 is the electronic method. So anything that we're opening up here at KDPH sits in their open investigation queue. They can see those and process those investigations directly out of that queue. For training purposes, for today, we're going to focus a lot on PCR positive cases. Probables based on serology get kind of fuzzy, if you will. So we're going to talk a lot about how to process a PCR positive case and how that feeds into CTT, the Deloitte Contact Tracing and Tracking System. And then processing the probable cases, I'm going to leave up to the local health departments because they probably have a system in place just for those that we are not addressing here. So I don't want to contradict anything that they're saying. So with regard to probable and suspect cases, get in touch with your regional IP and find out what that local health department is doing. I do want to mention, as far as like notifications, that's moving the investigation from level to level. Every time you go into an investigation in NEDSS, if you edit and add something new, that transmission to DPH and to CDC is updated with any kind of additional information as long as you have an approved notification. So really the notification is meant to be created when you meet definition, and then you update the details of the investigation. So additional contacts or symptom resolution dates, you can do that after you create a notification in the system, and everything will update automatically. That notification is often used as a tracking system for local health departments. So that's another thing that regional coordinators, you're going to have to get with your regional IP and find out when they would like for you to create that notification. KDPH staff, if you're on here, we're not going to create notifications at all. And then one more thing about NEDSS, and this as it pertains to the data flow, is that it's essentially a real-time communication device. So if we put everything that we see on paper here at KDPH into NEDSS, then as soon as we click submit and kind of save our work, then the local health department can see everything that we've done. And so the same with the local health department, if they're entering everything that they have into NEDSS, we can see what they have. So it's really, it cuts out the need to notify via email or fax any kind of reports that we have, and hopefully makes it easier for us to reconcile counts from the local health department and from KDPH. We want that count that the governor is giving every day to be consistent with what the local health department knows, and so this offers us a way of doing that. Once that notification is sent and EPI subject matter experts review and approve, then we do some state level analysis. We have an outbreak management tool here that we pull different distributions for. So we're pulling out of NEDSS, putting into that system and then doing some analysis. For regional coordinators and disease investigators that will be doing contact tracing, any NEDS investigation that is created will feed electronically into the Deloitte Contact Tracing and Tracking System, or the CTT system. So you don't have to manually enter a case into NEDS and then into Deloitte. If you put it in NEDS, it will flow over to that Deloitte CTT system. And then you can do your public health interview and your contact tracing within that system. Just a quick overview of the public health investigation for staff that has never completed one in the past. It really is basically 4 main parts. So you get your healthcare provider report, and if you're missing anything in that report, you do a medical record review. So calling that ordering provider or calling that attending physician and obtaining additional patient demographics or the clinical laboratory or epidemiological data that you need to meet case definition. You'll see once you get into NEDS and into CTT, because it's fed by NEDS, that you can get pretty sparse information from labs especially, and also may never get a healthcare provider report on a patient that was tested for COVID-19. So it's important that you know that you can call that ordering provider, call that attending physician, and gather any kind of additional details that they may have. So lab test results, patient demographics, epidemiological data that they gathered during their history, the patient's medical history, all of those things can be gathered through the medical record review. Additionally, you're going to ask the patient some questions during their case interview. You're going to confirm their patient demographics, because healthcare providers can also have incorrect data for that. You're going to be asking them about exposure data. So how did they get exposed to become a case of COVID-19. Also obtaining contacts from them, and then you're going to be reinforcing isolation instructions and making sure that their isolation needs are met while they're in that time period. The CTT system will have a questionnaire and a script written. So really all you'll have to do is follow that script and fill in the details. But the additional trainings that you're going to get through ASTO and kind of that training matrix will kind of give you the background knowledge that you need to have to understand why we're doing this and kind of what we're asking of those cases. For contact tracers, anybody that we've identified from the case as a contact will be interviewed as well to make sure that they're not symptomatic at the time that they contact them, and then daily after that during their incubation period to find out if they start to show symptoms and then turn into a case. So again, questionnaires and scripts will be available within the system. You'll just have to read off those prompts and fill in the details, but you're also going to be providing quarantining instructions and ensuring that their quarantining needs are met. And then lastly, your investigation obviously has to have a reporting component. So the majority of the reporting is going to start in NEDS, and then once that case is created in NEDS, you're going to fill in the details from the interviews and from the tracking and tracing in CTT. I do want to mention that some of these workflows, policy decisions between NEDS and CTT are evolving as time goes on. We're right now, I think, in a soft launch of the system, and so we have some jurisdictions out there that have access to CTT, some that don't, and we're working out kinks both within the system and in training. So if you are having trouble understanding the flow between NEDS and CTT, or you get into CTT and you're confused about something, I'd encourage you to let us know, because we want to build this to be a system that is useful across the state with as many local health departments as we have. It can, it's very easy for us to forget or not know the actual needs on the ground. So if you're seeing a training need or you're seeing a glitch in the system, let us know so that we can fix it. As far as in Kentucky, every jurisdiction will come up with their own outbreak definition. For COVID-19, that's not any different. We do use CSD, or the Council for State and Territorial Epidemiologists, recommended definition. And I think we have modified that to meet the needs of our state. So in that definition, which you should have access to on the P drive for regional coordinators at least, you have a combination of clinical criteria, laboratory criteria, and epidemiological evidence. And those combinations fit into 3 different case classifications: confirmed, probable, and suspect. I just want to go through really quickly some of the clinical criteria, laboratory criteria, and epi evidence that you'll need so that when we go through each of the classifications, you'll have kind of an idea. The clinical criteria for COVID-19 is at least 2 of the following. So fever, either subjective or measured. So either they've taken their temperature and they have a fever, or they feel like they have a fever. Either of those count. Chills, rigor, myalgia, headache, sore throat, or new olfactory and taste disorders. So 2 of those, or you could have 1 of the following, which is cough, shortness of breath, or difficulty breathing, or clinical or radiologic evidence of pneumonia or acute respiratory distress syndrome, and no alternative, more likely diagnosis. So I'd encourage you to get that case definition, read through this clinical criteria, and kind of commit it to memory, because this is really the backbone of what you're going to be looking for your public health investigation, what you're going to need to enter, and sets up the justification for us gathering additional information from healthcare providers and isolating and quarantining people. So make sure you know what clinical criteria is needed to meet definition, what laboratory criteria, epi evidence is needed, so that we have done our due diligence in our investigations. As far as laboratory criteria, we are using 2 levels: a confirmatory lab test and a presumptive laboratory evidence. So confirmatory is a molecular test. That's the nucleic acid amplification test, or PCR is what you'll see it. And that's really detecting the actual pathogen, the SARS-CoV-2 RNA that people are infected with. Presumptive laboratory evidence is detection of an antigen in a clinical specimen, detection of antibodies in serum, and that is detecting a person's, for antibodies at least, a person's reaction to infection. There are some limitations with that, so we assume serology to be presumptive, whereas the PCR is really confirmatory. As far as epidemiologic evidence, you need to have the following: 1 or more of the following exposures in the last 14 days before symptoms onset: close contact with a confirmed or probable case of COVID-19, or close contact with a person who is clinically compatible and is linked to a case of a confirmed case of COVID-19. Someone who travels to or resides in an area with sustained ongoing transmission of SARS-CoV-2, or a member of a risk cohort as defined by public health authorities during this outbreak. So the epi evidence is really connection to a confirmed case, or, we feel confident that they've been in a place where they've likely been exposed in the community. If you have any questions when you do your public health interview as to whether or not this person meets the epi evidence portion of the case investigation, get in touch with your regional epi, get in touch with the subject matter experts here at the state, and we can kind of talk through the individual details of that interview and help you make a really good determination about whether or not you meet that part of the definition. Confirmed cases are really the easiest, I think, at least. You really only have to have that laboratory report that says you've got a detection of the virus in the person swab. So you're looking for detection of SARS-CoV-2 RNA in a clinical specimen using that molecular test. It'll either say NAAT, PCR, you might see molecular test, just basically you're looking for nucleic acid of the pathogen. And that's all you have to have. So for a confirmed case, we don't care what symptoms you had. If you had any, it's possible for someone to be asymptomatic. And so if you have that confirmed test, then you really don't need much else. But we do want to do a contact investigation so we can isolate any of your contacts. For probable cases, this is where things can get kind of fuzzy. You've got 3 different levels. You can meet the clinical criteria and have epi evidence, but no confirmatory lab test, or meet the presumptive laboratory evidence, so you're serology positive, and you either have you meet the clinical criteria, or you have epi evidence, or finally you meet vital records criteria with no confirmatory lab testing performed for COVID-19 at all. So this is, these are a little less straightforward than that confirmed case classification. So in order to meet these definitions for probable cases, you're going to have to do more investigating, whether that be through medical record review or public health interview, to know if you meet that definition. So we need to know who they were in contact with in those 14 days before symptoms started, what kind of lab test was done, and then kind of put all that together and make a determination as to whether or not this is a case. I forgot what I was going to say. I'll come back to it. So lastly, suspect cases are cases that meet the clinical criteria and are epi-linked to a confirmed case, but they have a negative confirmatory lab test result. So it is possible that somebody with a negative test result can be a suspect case if you have enough evidence as far as, this case was symptomatic, meets those stipulations of the clinical criteria, and is epi-linked to a confirmed case. So I think our general mentality is that a negative just doesn't have to be dealt with any further, and that's really not the case. If you've got a household that has a confirmed case and they've tested everyone, and dad has a cough and was short of breath, but a negative test, and son who lives in the home actually has a positive PCR, then that is going to be a case. So your public health interview and epi-links are very important. It's not just a lab test result. Any questions about case definition before I move on? You might have to unmute yourself to ask questions, I think. Okay, I'm going to, before we move on to labs, I am going to try to get these questions out so that I can answer some of them, because I see we have some questions. So, out-of-state lab. You all hear me now? I muted myself. Out-of-state labs do report via paper depending upon who they are. So LabCorp and Quest are national reference labs. A lot of those do report electronically. We are working to get additional labs on board to report electronically too. Our reg is really for Kentucky facilities. So it's definitely a one-on-one conversation with those out-of-state labs to see if they'd be willing to hook up to our health information exchange and report electronically.
You don't have any speakers, so we can't unmute anybody. I can hear them, but you could. So they'll need to submit their questions through the question box.
Okay, got it. Okay. If anybody didn't catch that, make sure you're putting your questions in the question box so I can answer them, because I can't hear you. is there any standard how information should be sent to the LHD? So within the reg, you have a couple of forms that can be used. Those are standard forms that you'll hear it called the EPID 200 or the reportable disease form. It's got some patient demographics, some disease-specific info, signs and symptoms, and lab test sections. We would like for those to be filled out. For COVID-19, we have a person under investigation form. So if a healthcare provider is testing someone, they come back positive, we would like for them to fill out that PUI form. And that's really, very detailed information about the person's medical history, the signs and symptoms that they presented when they came to be evaluated, things like that. So we would like to have that. If you are not getting those case report forms and having to call the healthcare provider over and over to gather those, just give them a copy and ask that they start filling those out. And then for the most part, and this is like, I guess, the method to send those transmissions, so they can fax it, they can they can phone it in if they'd like, but I don't think the local health departments are going to want to complete that information. So as much as they can fill out on paper and then fax in, that's great. Some of the local health departments have secure email systems that they can use. If that's a possibility, then the healthcare provider can secure email that in. You have to have a secure email transmission in order to send patient information. So for DPH staff, anybody with a ky.gov email, you have to put #encrypt in the subject line in order to send patient information via email. All the stuff is available, like forms are downloadable. They are not fillable PDFs, however, so you'll have to fill them out with a paper and pen, scan and email, or scan and fax, excuse me. Okay. I think those are all the questions for right now. The next thing I want to go through is just the types of labs. So I know we have kind of a mix of staff out there, and looking at labs can be kind of daunting if you've never looked at them, especially because you can have 10 labs send in lab test results for the same test and they all look different. So just some terminology and some things to keep in mind if you've not done, not had any exposure to these labs. Nucleic acid amplification tests, or NAAT tests, or AKA PCR tests, are really looking for nucleic acid of the pathogen. So this person is actively infected with COVID-19 and we are looking for that pathogen in their specimen. SARS-CoV-2 is the name of the actual pathogen, so you'll see that a lot. If you were around in the early 2000s, you know that we had an outbreak of SARS-CoV, and I guess you could call it one, a while back. It's a similar virus, still coronavirus, but the actual pathogen for coronavirus disease 2019 is SARS-CoV-2. For PCR tests, this is an NPOP or nasal swab. So they're sticking a swab up your nose, catching the back of basically the back of your throat, and gathering a specimen from there. This is really for individuals who are symptomatic, and this is the testing that is preferred for healthcare providers that are seeing symptomatic patients that they feel are likely to be diagnosed with COVID-19. Serology, on the other hand, is looking for your body's immune response to the virus. So you've been infected with it, and your body's created antibodies to that pathogen, and then in this blood test we are looking for those antibodies. So you'll see a lot of times IgG or IgM. IgG is a long-term antibody that usually comes up later in the progression of disease, and we don't typically use that to indicate acute infection, at least in public health definitions. If we're going to use serology, we use IgM because that comes up much more quickly in the progression of illness and then declines, and then IgG picks up. So I don't know if we have it for COVID-19, but if you ever want to see kind of a graph of, viral load versus antibody production and what comes up first and what comes up later, I can provide that to you. But I think the problem or the thing you need to take into consideration with serology is it is prone to cross-reactivity. So you could be positive simply because you had a seasonal coronavirus in the past, and we don't really know how long you will be immune to the virus right now. So there, with a novel pathogen like this, there's a lot of limitations with all testing really, but serology especially, because interpretation of the results is kind of up to the evidence that we have at that moment. So it's ever changing. If you have a case that has serology and they're symptomatic and you've caught them fairly quickly, I would follow up with that healthcare provider and see if they will call them back in for a PCR or a molecular test, simply because we want confirmed cases. We don't want to call anybody and say they're probable. I think it can be a little bit confusing, especially when we're asking them to isolate away from their family and friends and stay home. So we would prefer that PCR to serology. So if you catch them in an appropriate time frame, make sure to get in touch with that healthcare provider and see if they'll call them back for a PCR. A lot of times in public health, for laboratory criteria at least, what we use is great for a public health definition, but is not always consistent with what healthcare providers use diagnostically. So there's a little bit of a disconnect there. Most healthcare providers are willing to do just about whatever we need as long as they have access to testing supplies and a lab that will run the test. So if you do have to call a healthcare provider and bring somebody back in, they'll likely do that for you. But sometimes it's just an education point that we need to make with healthcare. Any questions on labs, those general labs? I'll keep looking at the question box. Since you all can't say anything, it might not make any sense to keep asking that question. A few examples of the two types of lab tests. So this is a nucleic acid amplification test, or NAAT, a PCR. You'll see right now a qualitative PCR, which is basically it's going to say detected or positive. You could start to see a quantitative PCR where they're measuring the actual viral load. If you do that, if we do start to see that, I guess, we can talk about levels, but for any kind of quantitative, there should be a reference range, and if they detect anything, that is considered abnormal for that piece of equipment, then it doesn't matter what the actual viral load is. That would be considered a confirmatory test. For the most part, you are going to see the qualitative PCRs. Over there on the left side, that circled, you see that that's the name of the test. It says SARS-CoV-2 RNA COVID-19 qualitative NAAT, and then underneath that it says SARS-CoV-2 RNA. That's how you know that this is a NAAT or a PCR. In the middle, you've got the test results, so it's going to say detected or positive. You might start to see a numeric value there, and then off to the right, you've got some dates. So when we're looking at these lab reports, all of these can look different. This is a Quest lab report. They are easier to read than some of the others. Some of them can get pretty spotty, but you're looking for patient details, test details, results, and some dates. We want to know when they collected the specimen and when they reported that lab test result out. So those are all circled on that page. If you have any question about whether or not this is a useful lab, and we can use it for case definition, then follow up with your regional epi or follow up with subject matter experts here at KDPH. We'll review it and we'll troubleshoot from there. For serology, you're looking for basically the same thing, but instead of the SARS-CoV-2 RNA, you're going to see COVID-19 IgG antibody or COVID-19 IgM antibody. You could also see COVID-19 total antibody, but it's going to be also a qualitative result, so positive or negative. I don't think we're going to have any titers drawn for this yet. So if it's positive, then you have an antibody result. A lot of labs will also have a reference range to give. It's mostly for quantitative labs where they're telling for that piece of equipment what if it's outside of this range, then it's an abnormal result. For qualitative results, it's not that big of a deal. It's basically the opposite of your test result. Again, you're going to want to look for patient details, test details, results, a reference range if you have it, and then dates. So we need a collection date and we need a date that they resulted that test out. Your collection date should always be before your test result date. For PCRs, that's usually about 24 to 48 hours unless the lab is completely backlogged. This particular patient, I think, is a part of a surveillance study, so I don't think this is diagnostic in nature. So it took almost a week to get that result back out. This is a lot of times from healthcare providers, you will get a full package of medical records. So you'll get patient demographics like a face sheet. It might include insurance info. It'll include medical history, some lab test results, and then kind of anything that they did at that visit. That's fine. If they send you everything that they have in their medical record, and you can find lab test details with those things in it, so patient stuff, test details, results, reference range, and dates. You don't need an individual copy of the test results, but just make sure that it's got kind of these details in there. In addition to that, if they are sending you a full packet of medical records, but they have not filled out a PUI form, you're not going to get very far if you call them back and ask them to fill out a PUI form with the information that they just sent you. So a lot of the follow-up with healthcare providers, at least for like medical record review and gathering info for your investigation, is going to be a balance between what they have time to complete based on their workflows and their staff and the patients they're seeing and what we need. And so my personal preference is to have the full medical record so that I can go through it and look through what they've done and what the patient has presented with, rather than just a PUI form where somebody might forget to fill in some of the details. So no real, again, back to this question of standardized information, we would like a PUI form, we would like an EPI 200, but if a healthcare facility, especially a hospital, is going to send us a full medical record, then that's okay too. That is, in a nutshell, a public health investigation. Without getting too far into how CTT is going to work. So now I really want to get into the bulk of like NEDS and how to enter cases into NEDS. We are going through click by click, for the most part, what you need to enter into NEDS. Again, this is going to be different between KDPH and regional coordinators and what the local health departments want to do. So if you have any questions, make sure to put those in the question box. If I'm moving through something too quickly or I've forgotten to put a click in there, make sure that you put that in the question box so I can address that as well. The National Electronic Disease Surveillance System is our surveillance system. It is a free product from CDC. Many states do use this system. Basically, the only thing that CDC says is that every state has to use a system that transmits electronically. nationally notifiable diseases to them so that they can do their annual counts. Even though many states use this system, they don't talk to one another. So if you are in a jurisdiction that's on a state line, you may see quite a few, especially from Indiana and Tennessee, NEDS reports where they've printed out a PDF of the data from their NEDS system, and then we have to enter it into our system. Additionally, we cannot send electronically our stuff in NEDS to them, to their NEDS system. So any cases that are initially reported in Kentucky but actually live in Tennessee and Indiana, we will need to send to our contacts there. So you'll have to like save a copy and print it, and then we'll have to fax it over to them. NEDS is a patient-centric system, so that basically means that we are building a patient chart for anybody that has a reportable condition, and that is from the time that we implemented the system in 2011, 2012 to now. So it is very possible that you will find your patient in the system and they've had a different reportable disease, and now you're just adding their COVID condition information to that. So we don't want to create a new patient profile every time that patient comes in. We just want to put our condition specific info into the existing patient profile. So we're going to talk a little bit about searching the system to make sure that we're using existing patient profiles so that we don't have too many duplicates. The system is composed of multiple events, and that's kind of the language that NEDS uses. Events are lab reports, and you'll hear either a lab report or electronic lab report or ELR when we talk about lab events. Morbidity reports, which are essentially case reports, that is more of an issue with other reportable conditions. We don't want to use morbidity reports for COVID-19, but it is a way that healthcare facilities can report some case-specific info into the system electronically. We have investigations, which are the bulk of the detail about the case. So morbidity, mortality, treatment data, exposure data, medical history, signs and symptoms. And then there is a contact tracing component to NEDS, but we aren't going to use that. In addition to the investigation, we have attached supplemental data. So any kind of paper-based documentation that you have, we want to attach to those investigations. And then finally, your notification, which is alerting the next level that we have this case and we need somebody to review it to make sure it's transmitted to CDC. For COVID cases in NEDS, for regional coordinators, every COVID case has to have the following things: a lab report, an investigation, attached documentation to that investigation, and a notification. When you create the notification, it's up to your local health department, but we do have to have all those things. Every case that we enter into NEDS, we want to be able to, at least from KDPH's perspective, we want to be able to say, if we've entered it, you have every piece of paper that we have, you know all things. And similarly, we would like local health departments to offer us that same assumption. So if you've entered something into NEDS and we want to know that if you have a PUI form, it's attached to the back. If that patient has been tested daily for the last 10 days, we don't expect you to enter every single one as an individual event, but we want to be able to see that there are lab test results for all those days. So lab report, investigation, attached documents to the investigation, and a notification. For KDPH staff, every COVID case will start with a lab report, have an investigation, and have attached documentation. So we are not creating notifications for local health departments. If you're entering something into NEDS for here at KDPH, we're not clicking that button. The general steps are meant to not only, so I have a question, what about the previous cases? Do we need to go back and upload the attachments? Yes. So the process here at KDPH, when we are monitoring fax documents, we are looking for those cases in NEDS and uploading any new faxes that come in. So let's say you have a patient that's tested every day for the next 10 days, and the lab sends us a new lab every day. That lab needs to be uploaded. Every lab for the next 10 days needs to be uploaded so that everything is in one place. Local health departments don't have access to our P drive. We don't have access to local health departments drives. And so this is the only way for us to know everything there is to know about the cases that come in, is if we put it into NEDS. So the local health department should have some way of managing their paper reports that ensures that all those physical documents are uploaded. The general steps for working a case, and this PowerPoint is really meant to go through a case that does not exist in NEDS at all. So we didn't receive an electronic lab report. We received a paper document, and that person does not exist in the system. So we're going to create the patient profile and then enter all the COVID stuff. At the back of the PowerPoint, there are some slides on the different scenarios for finding, patients in various levels of this process. But for every case that you work through, these are the general steps. So you're going to look for any physical documents. For KDPH staff, that is in the report disk folder, there is a directory. It will, if you search for the patient in that directory, it will tell you which subfolder their physical documentation exists in. For local health departments, you'll have to work with your regional epi and kind of find out where they're placing physical documents. If they don't have a process for scanning that stuff in, you'll need to figure out a way to put that into your regular workflow. If they're handing you a paper file, then you should take that paper file, scan it, save it somewhere, and that way you can use it for NEDS entry and easily find that document to upload at the end of this process. Papers, whether it be a PUI form or a lab report or an EPI 200, should all be used for data entry, so make sure you have them readily available. And then you're going to go into NEDS, search for the patient, either use the existing patient profile for that individual or create a new one. Then you're going to confirm the existence of a COVID-19 lab or create a new one. And we have a master line list here. You can use that to enter lab data, or you can use a physical copy of a lab to enter that data. At local health departments, they probably have the same thing. Basically, just use your resources to enter the data that you need into that lab. And then from your lab, you're going to either associate it with an existing investigation or create a new investigation from the lab report, and then upload any physical documentation. For regional coordinators, after that, based on your discussions with your local health departments, you're going to create a notification. So like I said, if you are at a local health department, your physical files need to be digitized in some way. So you're going to have to scan them and put them in a folder somewhere so that you can browse to that folder and then upload them. For DPH staff, you're going to start by looking in the directory, search, and find the subfolder where that patient's physical documentation exists, and then have it readily available so that you can enter data into the NEDS investigation and NEDS lab report. When you log into NEDS, this is your home screen. So you've got a couple of different boxes, but for the most part, you're going to be functioning in that top left box, which is the patient search box, and the queues. We need a scanner, for example, for our staff, if we need a scanner. Is that something we got? So if you need scanners for staff, talk to your regional epi about that. They probably have a mechanism. If they don't, get in touch with Brendan and let's figure that out. I don't think any of the local health departments are going to have a problem with getting you a scanner or having a scanner available. To point out the queues, this is my queue or what a state level staff will see. I think regional coordinators, I'm not exactly sure if you will have a state level profile or what regional FBC. We'll have to check on that. If you see what a regional FBC is, you're going to have the open investigation queue, the rejected notifications queue, and the documents requiring review queue. And those are really the only ones that you need. If you do have state level access, you won't have to worry about the rest. For any KDPH staff that's on today, you probably won't need to deal with those other queues either. But you can see that the documents requiring review queue is where all the electronic lab reports are going to go. That's where KDPH is monitoring that queue, taking those electronic lab reports and turning them into investigations. Once they work through that electronic lab report and turn it into an investigation, it pulls that detail into the open investigation queue. And that's where any investigation that you have open will sit. So if you have a case that was opened by KDPH staff and you're actively working with a healthcare provider to get additional information, that you can go to that open investigation queue and pull up that case. The queues are not just for COVID-19, they're for all reportable diseases. Granted, your queues are going to be predominantly COVID-19 right now, but that's not to say that there won't be other diseases and conditions. So you'll need to make sure that you're filtering for COVID-19 and only working on COVID-19 cases and not hitting a salmonella case or an E. coli case or anything like that. Rejected notification, so that is, let's say you send a notification to KDPH and the case does not meet case definition. The subject matter expert is going to reject your notification and the info is going to go back to that rejected notification queue. And so you're going to want to check that periodically to find out if, let's say you just didn't click a button or you didn't provide sufficient details for that epi evidence that you need to meet the probable definition. Check that rejected notification queue, open that investigation. The subject matter expert will put notes in for why they rejected your case, add that detail back in, and then create a new notification, and it will pull it out of that queue, send it back to DPH for them to review. For the most part, again, you're going to be looking in the open investigations queue. It is possible that your local health departments will want you to look for serology in the documents requiring review queue, but I'm going to leave that up to them. And then as far as the search box, you can search by last name, first name, date of birth, current sex, or event type. So those event types are the lab reports, the morbidity reports, investigations, and notification. So every event in NEDSS has its own ID. So every ELR is given an ID. Every investigation is given an ID. So if you're looking for that specifically, you can search by those ID types and pull up that patient directly. For patient ID, so like I said, the system is patient-centric, so we want one profile for one person. Every person is given a NEDSS ID. That is also known as the patient ID for this box or the patient local ID if we're running reports. And that will start with PSN1, have 6 or 7 numbers in the middle, and then have KY01 on the end. And so if you're searching for the patient ID using that PSN1 number, KY01, you'll have to take off the PSN1 and the KY01 before you put that in that box. And I can send some instructions on that if that's necessary. But that's usually the easiest way to find a specific patient. However, in this time where we have an issue with duplicates, we want to search in a way that allows us to find multiple patient profiles. So let's say you get a report from a healthcare provider on Jane Doe. If you search a common name like Jane, probably not Jane Doe, probably more like Jane Smith. using first name and last name, you will only get a total of 100 results in NEDSS. So for common last names, it's very possible that that individual exists in the system, but you won't find it because NEDSS can't function with more than 100 results. So it's not like Google. It doesn't have a great search function. Common names, you will have to be very careful with. And the same with names that the order could be inverted. So instead of putting Jane as the first name, Smith as the last name, somebody has entered Smith as the first name, Jane as the last name. So you really need to come up with kind of a balance for finding multiple patient profiles and using the correct patient profile while not kind of hitting NED's quirky ability to not find your patient. So if you want an example, I searched for, I think, a patient similar to like Jim Smith. I searched with the first letter of the first name, first letter of the last name. I couldn't find the patient because there were too many results. I did the same with the first 2 letters of each name, still couldn't find the patient. I did it with the first 3 letters of each name, still couldn't find the patient. So common names, it's very easy to miss your patient profile. Here lately, I've been suggesting that people search with a date of birth and sex because it seems like we're able to identify duplicates if there are misspellings in the name or the system didn't recognize that there was already an existing patient profile. So I would search for date of birth and sex if you have kind of a common name, and then always, always, always search 3 times and be confident that your patient doesn't exist before you create a new patient profile. You will come up with scenarios where you have multiple patient profiles and those patient profiles are devoid of a lot of information. So especially with ELRs that are sent from labs, you can send an ELR without a name or without a date of birth and just a test result. So when you do a search, you could come up with patient profiles, and it's going to be impossible to match your patient to that existing patient profile. It could look very, very much like that is the correct patient, but if you're not confident, don't use an existing patient profile. There is staff up here that can merge cases, and that is better than we can't unmerge anything. So once you merge things together, the only thing that we can do is manually re-enter those lab reports and those investigations in new patient profiles. But once you merge, it's not always totally apparent who each of those patients are and what belongs to who. So make sure that you're searching for patients and using existing profiles, but you're also confident that you're using the right patient. There are some access restrictions within NEDSS to protect the privacy of patients, especially patients that have STIs or HIV. So for those, we can see some of the info, mainly the patient demographics, but you can't see any kind of lab test detail or investigation detail. So if you're not confident, just create a new one and then send a question to DPH staff or to your regional FB, and we can always merge them later. Feel free to ask any questions about merging because I know it's a balancing act and it can be kind of confusing. Once you search your patient in NEDSS, if you don't find anything that NEDSS cannot come up with anything that looks like what you searched for, you'll see that top box and it'll say nothing found to display. More likely, you are going to see a list of patients that NEDSS is including in the search, but doesn't actually match the patient that you're trying to enter. So if you're creating a new patient profile, click that Add New button, and then you will get a screen called the Add Patient Basic screen, and that's where you're going to enter your patient demographics. Anytime you see those white boxes, that's NEDSS version of edit mode. So that's when you know that you can put something in those fields. For KDPH staff and what we're telling people up here, we have a list of variables that are kind of the bare minimum that we want entered into the system. For local health department staff, make sure you're working with your regional FP to find out what they want entered. The main thing is for the variables that we're putting on this webinar and that we're reporting out on a daily basis, we don't want blanks. So if there's a drop-down box and you can put unknown, put unknown. If it's a text box and you can put unknown, put it there too. So blanks, we don't feel comfortable making an assumption about here at DPH. So we need to know if you truly don't know the answer, or you know, and therefore it is an unknown field rather than it's left blank and we don't know if you don't know it or you didn't ask the question. For patient demographics, we want first name, last name, date of birth, sex. If the patient is deceased, their address, county, ethnicity, race, and phone number. For mortality, here at DPH, we are putting no if we are for sure that the patient is not deceased or if we don't have any data there. We don't want any blanks in mortality. So unknown, unknown status, or known no, as far as the patient being deceased is going to be a no. If you know the patient is deceased, make sure to mark it yes. Put in as much as you can. If you're using a paper lab report, you're probably going to have first name, last name, date of birth, but you might not have much else. So whatever you can enter. When you can enter unknown, enter unknown. Phone number is rather important, at least from DPH's standpoint, because we want local health departments to be able to contact those cases. So if you have a phone number on your report, make sure you put that in there. Race and ethnicity should be marked as unknown if you don't know it. If you do have that data, then make sure you're entering that. Race is a checkbox and you can select all that apply. Ethnicity is a drop-down box. Address and county, use what you have on your healthcare report, knowing that that jurisdiction can be changed later on. So we can, let's say you get a case that has their address is right on the Shelby County, Jefferson County line. If you enter that because you're in Shelby County, but you later find out that that person actually lives in Jefferson County, we can always transfer the jurisdiction. So enter with the data that you have, and then we can always move it later. Once you've entered everything from your healthcare report, click submit, which is on the top right, and then we can move on to adding the lab report. The general steps of adding a lab report, if you don't have anything, is navigating to the events tab on the patient summary page by clicking the events tab. Create a new lab report by clicking add new on the lab reports row. Enter your lab data and then submit and create an investigation. For creating lab reports, whether that be a case that has an existing investigation or for a case like this where you're entering an investigation for them, if you don't associate that lab with the investigation, your lab is going to kick back to the documents requiring review queue, and then somebody at KDPH isn't going to process that, and it provides the possibility of a duplicate, which is what we don't want. So when you are entering a lab report and you have to create an investigation for a case, always click submit and create an investigation. We'll get down to a scenario where you have an existing investigation, you're just entering the lab report. We'll talk about how to deal with that so that you don't end up in the documents requiring a review queue. But for this scenario, just keep in mind that you're always going to submit and create an investigation so that we don't have a lab report sitting in our queues that someone else could then create a new investigation from. Click the events tab right there on the patient summary page. The summary page is basically anything new. So if you have any new labs that have popped up for that patient, it's going to go there. Any open investigations will be on that summary page, but really you want to be functioning on the events tab because that's where everything is. And if you're looking at the events tab, you can see closed investigations, open investigations, all the lab reports, all the reportable conditions, and that way you're not creating duplicates because you didn't see everything that was already entered into NEDSS. So click that events tab, and then under lab reports on that second row, you're going to click add new, and then that puts you in the add lab report edit mode, and this is where you're going to enter your lab data. So this slide is really for entering PCRs. We have a LOIN code, which is just like kind of like a code to pull up the right test so that you're entering the right test in as a lab report. Entering serology is kind of, again, an evolving thing, so we'll put out some guidance on that once we clear that up. That is ever changing, and I don't want to tell you something that we then have to contradict later. The reporting facility for a lab is always going to be the lab that performs the test. When you're entering a case, entering a lab report into NEDSS, it's most likely going to pre-fill with the Kentucky Department for Public Health or the local health department because that is the facility where the person entering the data works. We want to clear that out and reassign it to input the lab performing the test. So you click that clear and reassign button, and then you're going to have the ability to search for the facility that ran the test, your Quest, LabCorp, Diatherics, Mayo Clinic, anything that, anyone that might have performed the COVID-19 testing, and then you can search by name, address, state, a couple of different things, and that lab should pop up. If you have a lab that we haven't included in NEDSS yet, we can add that facility. But once you enter the reporting facility, it cannot be changed. So if you're entering a case and you have a lab that hasn't been included into the system, we want you to stop, send an email to the COVID-19 DR email box, which is monitored by KDPH staff, and have them enter that facility into NEDSS so that you can have the correct reporting facility. If you enter a lab with a local health department as the reporting facility, it will be rejected. The only exception to this rule is Louisville Metro, and that's because Louisville Metro Public Health and Wellness can run the PCR in their lab. So other local health departments, to my knowledge, don't have access to run those PCRs. They utilize the Division for Laboratory Services or the state lab. So if you put North Central District Health Department or the Kentucky Department for Public Health, the subject matter expert at KDPH is going to reject it and have you re-enter it. So just make sure that you're putting the correct reporting facility. There are 2 quick codes that you can use. If it's a lab from the Division of Laboratory Services, you can put DLS in there, or if it's UK, you can put 0800. The Division for Laboratory Services reports electronically, so you shouldn't have any paper copies that you have to enter, and I believe UK does as well, so those quick codes are probably not very relevant. Once you enter your reporting facility, you'll move down to that next box, that blue block, excuse me, and that's where you're going to put some of the dates in. The date received by Public Health is a required field, so NEDSS pre-fills that with the date that you enter the lab report. That might not be the correct date. So let's say your data entry in NEDSS is backlogged. You received the lab 3 days ago, but you're just not getting a chance to enter it. So make sure you change that date received by Public Health to the date that you actually got the lab. I have a tendency to use like the fax transmission date so that I can tell when the healthcare provider sent that lab to us. It is an important date because we can see if the healthcare facility or if the lab is reporting to us based on the timelines that we have in our reg. So make sure you change that. The lab report date is the date that the test was resulted out. So that should be at the, somewhere on your lab test result. but it should always be after the collection date. And collection date is on that next block down, and it's very easy to miss, but it says specimen collection date and time. Just pick the date that they collected the specimen, and then you can move on. You don't need an actual time. And then finally, the resulted test is where we're going to put that they performed the PCR. And that LOIN code that you want to search for is 94309-2. You're going to click the search box to the right of resulted test. Don't use the drop down. The drop down doesn't have everything in it, so you'll have to search for the actual test code. Hit long list, because if you don't hit long list, it won't pop up. And then once you get your PCR to pop up, and it's that very bottom box on the right side, click on the code link, and that will pre-fill the resulted test row with the PCR. The coded result is going to be whatever the result of that lab test is, so positive or detected. Numeric result for a qualitative test is just left blank. And then you're going to have to put in a reference range. So that is the opposite of the coded result. So if it's positive, your reference range is going to be negative to negative. If it's detected, then your reference range is going to be not detected, and then finally your status is going to be final. Those things are written down on the next slide if you need a reference. Basically, you want to recreate your lab on NEDSS so that it is exactly what you see on your piece of paper. Once you enter everything, you're going to click Submit and Create an Investigation. If you don't already have an investigation created, that pulls that lab out of the documents requiring review queue and ensures that we don't have somebody else working on the same case. So now you've created your patient, you've added your lab report. The next step is to create your investigation. You're going to pick from a drop-down menu of conditions and select 2019 novel coronavirus, parentheses 2019 nCoV from the drop-down. Enter all your variables into the investigation. Use whatever physical documentation you have. If you have a master line list at the local health department that you want to use, you can use that. Basically, any resources that you have at your disposal to enter the data. Click Submit, and then you're going to upload your physical documentation. For KDPH staff, that physical documentation is going to be on the P drive. For local health department staff, that's going to be wherever you saved it. So you've scanned it and saved it either on your personal computer, like your work folder, an individual drive, or if they have a shared drive, you can save it there as well. You are saving patient information, so wherever you're saving it, it needs to be, you need to be protecting the privacy of the patient in doing so. It needs to be a secure place. For our stuff on the P drive, we only provide access to those folders to staff that are working through these cases and that have signed confidentiality forms. So I would assume local health departments have the same setup, but just double check that privacy and everything that you're doing is HIPAA compliant. So here's the drop-down box for when you've clicked Submit and Create an Investigation. The next screen is selecting from that drop-down menu. Coronavirus 2019 is the first condition that pops up. Highlight it, click Submit, and now you're in Investigation Edit mode. For COVID-19 investigations, the page just switched. It went from a 6-tab investigation to 8 tabs. But it divides up the variables based on, case info, risk and exposures, clinical data, so medical history, signs and symptoms, some additional lab information, contact tracing and records, and then supplemental info. Some local health departments do use the contact tracing and records tabs. Moving forward, we will be using the CTT system. So you probably won't have to use those tabs moving forward. I'm not sure if at this point we have determined if the records that are in those tabs will pull into CTT. But if you're doing your investigation in CTT, then you shouldn't have any problem. The variables that are on this slide are things that we need to confirm the case. So this the bare minimum that we need you to enter. Again, enter everything that you have. If you don't have it and don't know, enter unknown. But in order for you to send an investigation as a notification, you have to have a case status, and that is a case classification. So you'll have to go to the case info tab, scroll to the bottom, and pick confirm, probable, or suspect. We would prefer that you not pick anything that is not included in the case definition. So some local health departments will default to an unknown case status. That is just something that we have to go back and fix later. So if you've looked at the case definition and you've looked at your data that you're including for this case, make a determination, and the subject matter experts that are reviewing your notification will change that case status if it doesn't meet. But try your best to at least put confirm, probable, or suspect when you're entering. Mortality info, if you've created the patient in NEDSS, then that info that you entered when you created the patient profile will pre-fill into your investigation. If you are using an existing patient profile, you're going to have to enter that in the investigation. So make sure that's completed, checking that patient tab or the case info tab to ensure that it's accurate based on the information that you have at that time. The next must-have variable is the CDC 2019 NCOV ID, and that is capital K, capital Y, and the NEDSS ID, no spaces. That is the variable that has to be included for program staff at CDC to be able to see all these details from our NEDSS investigation. So when we transmit typically to CDC, we're only sending a subset of the data, and it has 0 patient identifiers. So it's really not very useful for anything more than a count. But CDC program staff that are working on COVID-19 want to be able to see everything that we have. If that CDC 2019 NCOV ID is not completed, or it's completed incorrectly, then that transmission won't get to them. So no spaces, and capital K, capital Y, and then the NEDSS ID. We do have someone running reports regularly and checking that, but if it's correct to begin with, that cuts down on a lot of that work. It is case sensitive, so you can't use lowercase and you can't use mixed case, just to be clear. Ideally, some of the other variables that we want to see are date of symptom onset, that's on the clinical tab, date of first positive specimen collection, that's on the case info tab. Date of report should fill in from your lab report if you've associated one. If not, that is the date of the lab report, the date that the test was resulted out. If the patient is a healthcare worker, when their symptoms resolved, if you have that, that's on the clinical tab. If the patient was hospitalized, if they're currently hospitalized, were they admitted to an ICU, what hospital, and what's their discharge date. You will see that these are evolving variables. So enter what you have at the time that you have it. So whenever you're entering the case, if you know that they've been hospitalized, put that in. If you know that they're a healthcare worker, put that in. If you don't, put unknown, and then you can go back and edit your investigation later. For resolution dates especially, go back in and add symptom resolution if you get it from your patient. Again, these are kind of the bare minimum variables that we want in the investigation. If you have more detail, put those in. For KDPH staff, when we're creating investigations for the local health department, we are basically doing quantity over quality. We don't want to get bogged down in the hundreds of variables that are in all these tabs. We just want to enter those variables for the local health department so that they can complete their investigation. They will fill in the details later. For local health departments, we want these as complete as possible. So once you get through a couple of them, it's pretty quick to enter all the data. As you go from tab to tab, the information does save. So I wouldn't your submit button is kind of like your enter button. You don't need to click submit after every tab. It will save it. NEDSS is glitchy though, so I will say that it's possible that you could enter stuff on your tabs and then NEDSS throw you an error and you lose it. Unfortunately, I don't have a fix for that. It's just kind of the nature of the system, and hopefully it won't happen to you. And I think it's happened to all of us though, so just be aware that it can happen, and NEDSS can crash every now and then while you're in the middle of doing something. Once you've entered everything on all of those tabs, you're going to hit submit on the top right, and that takes you out of investigation edit mode, and then you can start attaching your documentation. So you can't attach any kind of physical documentation while you're in edit mode. You have to be kind of just looking through read-only mode of the investigation, but you're going to click on that supplemental tab, scroll down to where it says attach documents, and then click add attachment, browse to wherever your document is for staff here at KDPH. That's on the P drive, or and the subfolder that you found using the directory for local health department staff. That's wherever you've saved it, and then click submit. You can only upload one file at a time using that dialog window or box, but once you navigate to a folder for that patient, if you have to add multiple files, you will be put back into that subfolder. So for KDPH staff, that's particularly helpful when you're navigating the many subfolders that you have to go through. For documents that need to be uploaded, again, that's any kind of piece of paper that you have associated with that case. For labs, especially with regard to healthcare workers or people that have work restrictions, if they're a positive case and they can't go back to work until they get a negative, under the events tab, we want the first positive lab entered as a discrete event, and then we want the first negative entered as a discrete event. Anything in between you can upload to this documentation section. So if it takes 10 days for them to pop negative, we just want that first positive and that first negative. Everything in between can just be uploaded. PUI forms can be uploaded. Medical records can be uploaded. As long as it's in a PDF format, we can upload it to that investigation. For down the road, where we have to enter this data on a state level into different systems, it's going to be important that we have access to all the physical records that local health departments have. So make sure you're uploading everything so we don't call you in the future and ask if you have something. Additionally, it's possible that you could start getting either reinfection, or you've got someone who had a bad test that proved them to be negative. So we want the first positive lab as a discrete event, the first negative lab after a positive entered as a discrete event, and then if you have a positive after that negative, then we want that as an event too, because we want to look at whether or not that's reinfection or if that was actually a false negative. So those are the three kind of labs that we need entered. Anything in between you can upload. Any electronic labs that come in for that patient, just associate all electronic labs with your investigation. It doesn't matter how many it is, just associate them all. For local health department staff only, once you have uploaded your documentation, the next thing you're going to do is click that create notification button. And that is simply what you do. You just click the button. Once you click the button, it will pop up with a dialog box. If you want to add any comments into there, you can. I would advocate that if you have a probable case and you're documenting that it's an epi link, put those in the comments somewhere in the investigation, not in this notification comment box. That way it's easier for people to find later. Every page, every tab on the investigation has a comment box. You can throw it in any of them really, as long as it's held within that investigation specifically. If there's something else, like for instance, if my notification got rejected because I put the incorrect reporting facility, when I send my new notification, I might put resubmitted with correct reporting facility. Just something to let the reviewer know why I'm submitting it. If it's just a routine, here's your first notification case and everything's perfect and there are no questions, you don't have to put anything in that box. So if you have any questions, that's entry from the case doesn't exist in NEDS at all the way through the notification. Now we're going to go through some scenarios that you might find in NEDS for all these COVID cases. So if you have any questions about the full data entry, just let me know. Again, NEDS is not a difficult system. Everything can be edited and changed except for kind of like unmerging cases and dealing with lab reports that have the wrong reporting facility. But it just takes a little bit of time of going through those cases to get a flow and to figure out where everything is. So give yourself some time, get used to the system, but know that it's not super difficult to navigate. So this slide is the patient exists in NEDS. And all those boxes are so that we protect the privacy of the patient when this is uploaded on Train. But let's say you search by name and date of birth or just date of birth and sex, and your patient pops up and there's only one search result. Your search results are going to have the patient ID or the NEDS ID, the name, address or age, date of birth, sex, address, phone, email, and some IDs. Under ID, you might have the social security number, you could have a medical record number. For inmates in state-run facilities, you can have the inmate number in this ID field. So all of those fields are ways that you can match existing patient profiles to the information that you have. Sometimes you'll get great info. Sometimes patient profiles are pretty much lacking in just about everything. If you see anything weird, you can send either an email to your regional EPI or you can send an email to the COVID-19 dr@ky.gov and we can look into it and try to fix anything that comes up. But compare those fields. If you think this is your patient, you're going to click on that patient ID link and that will take you to the patient summary page. Only use existing patient profiles if you're confident that they match. If you have an existing patient in NEDS and you pull them up, but there's no COVID documentation, you're going to enter a lab report, submit and create an investigation from that lab report, enter your data, and upload your documentation. For local health departments, based on their workflow, you're also going to create a notification. So let's say the next scenario, you have a COVID ELR, but no investigation. So you found your patient, you've gone to their events tab, and you see under their events history that they have the COVID-19 ELR. You want to open that ELR by clicking the date received link, review the info that you see, submit and create investigation from that ELR, enter the data, upload your documentation, and then create a notification if you're at the local health department. If for some reason you get a morbidity report, but you don't have a lab report and you don't have an investigation, a morbidity report will not be allowed as evidence of laboratory data. So essentially, you're just going to have to use the morbidity report to enter lab report information. So create a lab report under the events tab, submit and create an investigation from your lab report, enter your data into the investigation, upload your documentation, and then for local health departments, create your notification. If you have an investigation but no ELR, so the local health department has created an investigation, but they've forgotten to manually enter the lab report. All you need to do is enter that lab report and associate it with that investigation. Once you associate the lab report with the investigation, that pulls it from the documents requiring review queue. So you're not going to submit and create an investigation here. You're going to click submit and then associate. So enter all your lab details, hit submit. And then once you've clicked submit, you'll be given those 4 choices at the top right, that delete, create investigation, associate investigation, or print. Click associate investigation, check the COVID-19 investigation that exists, and then click submit. And that essentially bundles the lab report with the investigation for COVID-19 so that you have those 2 components of what you need. So another scenario, so under the events tab, you have a SARS-CoV-2 ELR, a COVID-19 investigation, and a notification, but they're not associated with one another. So really all you're looking to do is kind of bundle those things together so that the reviewer has everything under in one little package. So you can see when you go under the lab report on the column that says associated with, if that lab is associated with an investigation, it will have the investigation ID filled in that column. If it's blank, the lab report is kind of hanging out there by itself. So you want to go into that ELR by clicking the date received and then click associate with click the right investigation, and then that will make sure that that column is filled in with the COVID-19 investigation. A second scenario, under the events tab, you have a SARS-CoV-2 ELR, a COVID-19 investigation, and a notification created, but there are no documents. So essentially all the electronic reporting has been done, but you don't have any of your physical documentation uploaded, or the alternative to that is that you have some of the documentation uploaded, but you have something new. So basically all you're going to do is go into the events, go to the supplemental tab, the investigation, go to the supplemental tab, scroll down and attach your documentation. So really that's all you're doing is just uploading those extra documents. You don't have to create the lab, you don't have to create an investigation, you're just adding to the physical documents on the investigation. Just a couple of notes on NEDSS entry. If you find that there are any blatant errors, you can fix that when you're doing data entry. So let's say we have an ELR that comes in with a name and a jurisdiction, which is the county, but we don't have a physical address. If you are working through that case and you do have a physical address, make sure you update the address. If you have a name of an individual in NEDSS and you've talked to that person and you've actually found that that name on NEDSS is misspelled, correct it. The ELRs that come in from facilities are prone to error, especially misspellings and demographic information. So fix what you can if you have confirmed it. The best way to confirm a lot of that is through the patient. So when you talk to your patient, make sure you update anything that they've clarified. I have a tendency to utilize electronic information over written documentation. So if you've got an infection preventionist at a hospital that's filling out hundreds of PUI forms a day, it's easy to put the wrong name on the form or the wrong birthday or put the collection date as the person's birthday. It's just that anything that a human completes has a tendency to have errors in it. So I will usually default to any kind of electronic data first, and then if the patient can clarify anything when we do the interview, and then I'll go back and fix it. ELRs that come in from facilities cannot be edited, but the patient demographics can be. So you'll just, instead of going to that events tab, you'll go to the demographics tab and click edit, and then change any kind of patient demographics that are wrong. For KDPH staff, don't get bogged down in entering everything. Use those variable lists, the must-haves and the ideals only. If you do have additional detail, go ahead and enter it, but don't spend too much time looking for extra stuff. The bulk of the investigation is going to be completed by the local health department. For local health department staff, notifications can be created for cases as soon as they meet definition. You can create that notification and then come back and edit anything else. So if you, in order to get your case into CTT so that you can complete the rest of your investigation, you're going to want to just put in the bare minimum to meet definition into NEDSS. That way the case is created in CTT, and then you can fill in the rest later. And then come back and fill in NEDSS if you need to do that. But don't get bogged down in trying to complete all 8 tabs. Fill in the must-haves and the ideals, get your cases created, and then go back and edit later. For NEDSS, don't ever use the back button. It does not like the back button. It's finicky already. It's having a hard time keeping up with the volume of data coming in. So just try not to do anything that'll make it harder on you. If you use the back button, it might look like it's okay, and then the next click you make, it's going to throw you an error and you're going to get kicked out. Dates are also it's picky about dates, so you have to put dates in as month, day, year. If you mess up when you're entering that field, it'll kind of like stop your data entry progress, and you can get really mixed up. So whenever you're entering a date, just go back and make sure that it's entered it correctly. And then again, some of these quirks with NEDSS, they come up as you enter things. It is a system that that just has some limitations, and so once you get in there and look at it, those limitations will become pretty apparent. We have to work with them. Just be patient and open-minded. The other thing I would keep in mind with NEDSS is that there are going to be places where we require you to enter the same thing in multiple places, and that's basically so that we can easily pull the data out. So sometimes, especially with other diseases and conditions, you might put the date of specimen collection in the lab report, but if you don't put it in the investigation, I can't pull that out, and I can't do any analysis on collection date. So it's important that if we have asked that you put things in and it seems redundant, that you enter those things as asked, just because that might be the only way that we can pull our data back out. Just the way that the system's been designed, we need that redundancy built in. Does anybody have any further questions? I'll give it a minute so that you all can populate questions, but that's essentially the end of the training. Okay, well, I don't see any questions. You are welcome to get in touch with me or regional coordinators. You can get in touch with Brendan Matthews, and I think we have some other staff that are kind of acting as liaisons between NEDSS and CTT and local health departments and KDPH. So if you have any questions, let me know, and we can troubleshoot as time goes on. Have a good day, everybody.